right, welcome everyone. This is Dr. Lutku. I'm going to go over the cardiovascular physiology lecture for today. I love this lecture. Cardio with blood is a great unit. They go together very well. So that will be exam 2. And the heart is a really interesting part of the body. It's kind of one of the two places we think of when we think of ourselves is our brain and our heart. So it's one of my favorite units for that reason. It should be very relevant to everyone. So something to look forward to. If there's ever a unit that you feel is not relevant or less relevant, you're not getting as excited about it, you may have to fake it till you make it. Okay, it could be this unit, it could be the next unit, it could be any unit. And this goes for almost every class. So just some advice to you. Create something about that unit that you are excited about. Find a connection, even if it's a small one, and make it important to you. It will help you remember that topic long term. You can also pretend like you are teaching someone else that material, having to get excited about something you're not typically excited about. That will trigger the brain into thinking, hey, let's store this long term instead of short term. So just some advice for studying there. So we'll get through the heart. Some basics first off is that the heart is located in the thoracic cavity, specifically in this region called the mediastinum. The mediastinum is a space between the two lungs, right? Your left lung, your right lung. And it does help shape its neighbors, actually, the heart itself. If we were to look at the lungs, you can tell that the right lung is actually larger than the left lung, and that's because this left ventricle is so large in the heart that it actually takes up a lot of room that the lung would have had if it wasn't there. So we have this cardiac notch on that left lung, only 2 lobes of a left lung, but 3 lobes on the right. So very interesting to see these structures next to each other. Okay. All right, just to go back really quick, it's separated from the abdominal cavity here by the diaphragm. The diaphragm is what's going to relax in this case, and then expand to pull in air from the outside, right? So that's our most inferior part of the thoracic cavity, and then superior here, right where the trachea is located. Okay. All right, let's go through the coverings of the heart. We have a pericardium, which is a very fibrous, has a very fibrous covering on the very outside. When I say fibrous, I mean very tough. If you think about very tough leaves, right? They're fibrous, right? They're hard to get into. These are materials, if you were dissecting, you would need a scalpel for. Okay, when I think of fibrous in anatomy, I think, well, I got to go get my scalpel because I'm not going to be able to just move it apart with my fingers, right? There's that. Then the layer underneath that, so deep to the fibrous pericardium, which is right on top here, deep to that, we have the serous pericardium, and that has 2 layers, but really 1 layer that's folded in on itself. All right, so the parietal layer is going to be on the outside. It's going to be more superficial than the visceral pericardium. Visceral means organ, right? So one part of that serous pericardium is going to be directly on the organ, directly on the heart, adhered to the heart's tissue, right? So visceral, right on the organ. And the other is going to be on the outside, parietal. Think of perimeter, right? So on the outside. So if we're going from superficial to deep, we hit fibrous, parietal, serous, and then visceral, serous pericardium. You may see this shape and think, well, why does it need to fold in on itself? Why can't we just have those 2 layers? If you notice here, this fold creates a space. That space is called the pericardial cavity. That can be filled with liquid, a fluid, that is essentially a lubricant to keep the heart frictionless, right? You don't want every time your heart beats it to be rubbing against any of these tissues. It could break through those tissues. We don't want that. So there's some fluid there just to help keep that frictionless. Okay, this is also a cavity that can be filled with things that aren't supposed to be there. So if we continue learning about pathologies of the heart, we can learn this can be filled with blood, it can be filled with pus, it can be filled with air, it can be filled with water, it can be filled with really any liquid. We don't want it to be filled with any of those. Those are pathological, not supposed to happen. But they should be filled with a nice serous fluid that keeps everything frictionless. All right. Let's talk about the layers of the actual heart. So on the very outside of the actual heart tissue, we're not talking about what's covering the heart, actual heart tissue, we have the epicardium, right, which includes the visceral layer of the pericardium. When we think about the visceral layer of the pericardium, I want you to think of it as being completely ingrained into the tissue, so much so that it is considered part of that tissue. Okay, we'll see this in the brain too. We don't do brain in physiology, but if you were to do anatomy, you'll see this in the brain. The pia mater works very similarly. It's a covering, yes, but it is so ingrained that if you were trying to remove it, it would actually take some of the heart tissue with it, right? So it's completely ingrained. If you go deep to that, you get a very thick layer. This is the myocardium. That is a great hint. Love Latin, it'll tell us exactly what it means. So epi's on the outside, myo means muscle, and it's not a lie. Look how muscular that layer is. Okay, you go below that, you hit endocardium. Endo means on the inside. That makes sense. We've gone from superficial to deep, which means the endocardium is on the inside of the heart. So if we were to open the heart up and look at it, it would be this layer here. Okay, with the open lumen of the heart chamber directly underneath it, or directly deep to it, I should say. Okay. Pericarditis, itis, whenever you see that suffix is going to be inflammation. Okay, so in this case, it's inflammation of the pericardium itself, okay, of these layers here. Over time, if that gets inflamed, it's constantly inflamed, it can start to rub. That can lead to adhesion, so there's no longer that frictionless material in between. And so they'll stick together. That's not what you want. That can stop or even impede heart activity. Okay, so let's go over some misconceptions of the heart. All right. First of all, I would like to just discuss the overall goal of the heart, right? The overall, what is the heart trying to do? The heart is trying to pump. It's a pump. That's what it is. Blood to your tissues, okay? To every single tissue that there is, providing those tissues with oxygen and other nutrients, okay? That's what it's trying to do. It does not have any intrinsic oxygen in it, right? We don't breathe through our heart, right? It has to go to the lung to get that oxygen, bring it back to the heart, and then repump it, okay? So that's why there are so many different chambers and so many different valves going on, because we need to first go get the oxygen, bring it back to the heart, because the lungs can't pump and the heart can't breathe. So they need to work together in order to get oxygen to our tissues, okay, to all of those tissues. So we're working with the body, every tissue in the body, including the lungs. The lungs need oxygenated blood as well. And then the lungs specifically to go pick up that oxygen to repump to all of the blood's tissues. Okay, so let's go through that step by step. I typically start here in the right atrium. Where I like to start. You can start anywhere. It's a cycle. So whatever makes sense to you, I encourage you to start there. Okay, so let's start with this right atrium. Do everything with the actual heart in front of us and then move to the schematic if you're more of a schematic person. Okay, so we're in the right atrium. How did we get to the right atrium? Well, actually, the inferior vena cava and superior vena cava, huge, largest veins in your body, bringing blood back to the heart. Now, this I want to draw your attention to. Veins always, without exception, head back towards the heart. They're draining something. They're bringing it back to the heart. Veins do not always equal deoxygenated blood. And we'll get to that exception later, and that's because of the lungs. We have to go get the blood first. Okay, so there's going to be a little exception when it comes to deoxygenated blood, but veins will always go back to the heart. So if it's going back to the heart, it's a vein, in this case, superior and inferior vena cava. They're going to dump out into this right atrium. Okay. And then once they're there, if they wanted to, they have to get into this right ventricle. So they have to go through this tricuspid valve. Okay. These chordae tendineae are going to be pulled by these papillae, these muscular papillae, that open the valve and let the blood through into that right ventricle. Okay. Once you're in that ventricle, you're ready to go. But where are you ready to go? You just came back from all the body's tissues. The body's tissues just gave you a bunch of carbon dioxide. Okay? We can't repump that. They don't want the carbon dioxide again. They want oxygen, but we don't have oxygen. And the heart doesn't have oxygen itself. So where do we need to go to get oxygen? The lungs. Okay? Now here's the thing. You may ask yourself, well, if I was already in the heart and I needed to get the lungs, why can't I just go from the right atrium to the lungs? Why do I need to go to the right ventricle at all? It seems like a wasted step. And in many species, they don't even have 4 chambers, right? They have 2 or 3. So that's a great question. Humans are very efficient, actually. We have 4 chambers. And what this extra valve here does, this tricuspid valve, one of the atrioventricular valves that we have in our body, it allows the blood not to go backwards. Okay, if you were to squeeze this right ventricle and send it out to the lung, right? Part of it would shoot out backwards and straight back towards those tissues again, right back where they came, opposite way in a vein. You don't want to go away from the heart in a vein, you want to go towards the heart in a vein. So what this does is it seals off the vena cavae, right? The plural of the superior and inferior vena cava, seals it off. So now, when the blood gets squeezed, the only way it can go is towards the lungs. It's the most efficient way to do it, have those 4 chambers. Okay, if you only had 2 and you squeezed one, some would go the opposite direction, and that's not very efficient. So, lucky us, we have those 4 chambers. That tricuspid valve is going to seal shut so we don't go backwards. This semilunar valve, specifically the pulmonary one, it goes to the lungs, pulmonary means lungs, is going to open, allow us to squeeze the blood out of the pulmonary trunk into the left and the right pulmonary arteries, because arteries go away from the heart. And that's our deoxygenated, oxygenated blood exception, because arteries typically have oxygenated blood, right? But if we don't have any oxygen yet, we're going to the lungs to get oxygen, then this artery, by definition, is deoxygenated. It's the one exception to oxygenated blood. But A always means away. Since we're leaving the heart, we know these must be arteries. So there's a left and a right pulmonary artery. If we go back to this first image, we know it's in between the lungs. You've got a left pulmonary artery and a right pulmonary artery heading to the lungs to pick up the oxygen we need to then come back to the heart. Okay, so we went to the lungs, we got our oxygen. We now are bringing it back to the heart. If we're going back to the heart, are we a vein or an artery? Vein. Veins always head back towards the heart. Now, do we have oxygen in that vein? Yes, because we just got back from the lungs. The lungs gave us oxygen. So we are ready to go. We have oxygen in the blood. The lungs can't pump, though. It's not a pump. It's just there to get oxygen. So we've got to go back to the heart so the heart can pump that oxygen to the rest of our system. Okay. So from the lungs, we get these left pulmonary veins. They're veins because they're going to the heart. They're going to dump that oxygenated blood into the left atrium. And then that bicuspid valve, also called the mitral valve, those are, you can use either one. bicuspid or mitral. That's going to open, allowing the blood to fill in that left ventricle. Left ventricle is the largest ventricle of the heart. We saw that here. It's so large, it's even cutting into some lung space. There's only 2 lobes of the lung, and there's a cardiac notch because of how big that left ventricle is. And it's larger and more muscular here because it has to pump not just to the lungs, no, but to every tissue of the body. It has to pump to the entire body. The whole systemic circulation has to pump to. So once the blood has filled there, it's oxygenated, it's ready to go. That seals off. Bicuspid valve's now closed. Mitral valve closed. Where do we want to go? We want to pump that to the rest of the body. We do that out here through the aortic semilunar valve, not the pulmonary. Pulmonary is going to the lung. We don't want that. We don't want it to go. We want it to go to the rest of the body. So that's the aorta. Aortic semilunar valve goes through the aorta to all of our tissues of our body. Okay. In a schematic, here it is. So if you're not a visual person, you like the words, this is exactly there for you. Same color coding, right? So blue is deoxygenated, red is oxygenated. Does not mean red is artery, blue is vein. No, because there's always that lung exception, right? Because the heart doesn't have oxygen itself. So when it goes to get oxygen from the lungs, you're dealing with arteries. When you're coming back from the lungs, you're dealing with veins, because veins always go towards the heart. So just make sure you draw that out as many times as you need to understand that circulation. Okay, so from the superior vena cava and coronary sinus. The coronary sinus, I'm not sure if it was labeled here, but essentially what the coronary sinus is it's the heart's own drainage, essentially. So the heart tissues itself needs blood, right? Your heart is a tissue or has tissues. So it needs oxygenated blood as well. So the heart will pump blood to itself and it drains to that coronary sinus when all that oxygen's used up to get repumped going back to the lungs. So that all gets to the right atrium, goes through the tricuspid valve to get to the right ventricle. You go through the pulmonary semilunar valve to get to the pulmonary trunk and the pulmonary arteries, left and right, to the lungs. The lungs, there's a gas exchange. You're exchanging carbon dioxide for oxygen, right? Depends on which side of the capillary you're on to see if you're oxygenated or deoxygenated. And then you take the pulmonary veins back to the heart, because veins always return to the heart. Now you're in the left atrium. That's great. I want to be in the left ventricle, so we have to go through the bicuspid or mitral valve. Once you're in the left ventricle, you're ready to go to the whole body. And you do that out that second semilunar valve, the aortic semilunar valve, and out the largest artery in the body, the aorta. Okay. Here are our valves, right? So this will re-explain exactly what I've already gone over. To explain this image, though, you're going to have to kind of rotate these objects in your mind, okay? So if we look at this heart, if we rotated it towards us on the screen, so it's in front of us, if we rotated it towards us, and then cut through transversely, so if we cut it here, right there, and then tilted it towards us, we would see this image, right? So we can see those valves quite clearly. See that pulmonary semilunar, right? So blood is leaving to go to the lungs. It's blue because it doesn't have oxygen yet. If it hasn't been to the lungs, it can't have oxygen. The heart doesn't have oxygen. The aorta, semilunar valve, out to the rest of the body. And then we have our AV, atrioventricular valve between them, atrioventricular valve between them. Okay. All right, bicuspid, tricuspid. Okay, now the semilunar valves open and shut together. So blood exits the heart and comes back together. That's because if you think about the heart, it's a muscle, it squeezes, right? It can't do both at the same time. It either needs to be filled, right, filling up, or it needs to be contracted and ejecting the blood. You can't do both at the same time, one or the other. So either both of your semilunar valves are open, both of them are closed, and then conversely with that, the atrioventricular valves are both open or they're both closed. Okay, so when the semilunar valves are open, the AV valves are closed by definition, and the opposite is true as well. So ejection will occur after you fill, right? It kind of has to happen in that order, although it is a cycle, right? And those have particular words. So first, to fill the ventricles, remember to fill, we just got to the heart, right? Or got back to the heart, either way. We want to fill the ventricles with blood, so these have to be open. We can't fill those with blood if these are shut, because then no blood can come in. So these are open. Both the tricuspid and bicuspid valves are open. Blood comes in to those ventricles, fills up. Okay? That is diastole, the filling. Okay? Semilunar valves better be shut because we don't want blood going anywhere else. We just want blood to fill the heart chambers, the heart ventricles. Okay? Once that's done, we can head into systole, which is the ejection phase. It's when the heart contracts, right? And that's going to shoot blood out of the heart. Well, to go out of the heart, we're going out of those semilunar valves, either to the lungs to go pick up oxygen, right? Or to the whole body to give oxygenated blood to those tissues. Okay, so this is just another diagram showing you. I really practiced with this image. This is a great image, right? Well, practice with the first one too, but maybe even start with this one to get a general picture of just what's happening in your mind. And once you understand when you go to the lungs and when you go to the body, then you can go to the specifics, right? Don't get bogged down by those details until you understand that big picture, okay? So we came back to the right atrium from the body's tissues. They were like, we have all this carbon dioxide, take it, take it, take it. They're going to put it in the blood. Veins are going to take it back to that right atrium. Okay, it's going to dump into the right ventricle. It doesn't have any oxygen. It's carbon dioxide. It's deoxygenated. We need to get that from the lung. When we got it from the lung, we have to go back to the heart. When we go back to the heart, veins always go back to the heart. So this is the one vein in the body, right, that's got oxygenated blood because we're taking it back to the heart so we can pump. Lung is not a pump. Heart doesn't have intrinsic oxygen. Okay, so we work together to get oxygenated blood to all tissues in the body. Okay, we end up in that left atrium. We got to get to the left ventricle. Got that bicuspid mitral valve opening. That fills. We're ready to go to the whole body, out that aorta to the whole body. Again, I choose a random spot on this and see if on paper you can do the whole cycle yourself and why it goes there. Okay, I'm not going to spend a lot of time on all the differences between veins and arteries. I do want to hit some major differences. First, veins are low pressure. Arteries are very high pressure, right? Your heart has to give blood or push blood, pump blood to the entirety of your body. That needs to be a high pressure system, right? When blood is draining back, it actually does so against gravity. And since it's low pressure against gravity, your legs especially have these valves in them that catch blood in case it starts to go in the opposite direction. So it kind of pushes the blood back to the heart. Another major differences, so arteries don't have any valves anywhere. Arteries are elastic. Since it's such a high pressure system, arteries actually expand quite significantly. And so we have this these elastic layers here, right? You can see those elastic layers. So two elastic layers in the artery that we don't have in the veins. And a major difference you should see here visually, this tunica media, which means muscle, right? So media, M for muscle again, so we have myo for muscle. And now we have media for muscle. Okay, very thick in arteries, the muscular layer, very thick. We still have that smooth muscle layer in the veins, so that's not a complete difference. It's just a relative size difference. You need to be able to constrict those vessels more strongly in an artery because of the high pressure than on a vein, which is low pressure. Something to note, medication that is targeting vasodilation or vasoconstriction, so whether or not your vein or artery is going to be dilated or constricted, right? So wider or thinner, right? So high blood pressure is going to be thin, lower blood pressure is going to be wider, dilated. Those control or are targeting the tunica media, right? Because the muscular layer is what tells you whether that artery or vein is constricted or dilated. Okay, so we'll see this in lab. We have auscultation of the heart, which is just listening to the heart. We'll do this with a stethoscope. Okay, you'll probably notice just from media and everyday life, but also if you've ever used a stethoscope, that the heart has a lub-dub sound to it, right? It goes lub-dub, 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 that boom-boom heart, right? The heartbeat sound is lub-dub, that we've scientifically named it that because it sounds like that. The S1 and S2 is what we've ascribed those, okay? So S1 is referring to the lub sound, S2 is referring to that dub sound. Remember, systole, the ejection phase, and diastole, the filling phase, these are lub and dub, essentially, okay? Let's go over which one's which. The first sound, lub, S1, is produced by the turbulent blood flow through the AV valves. And so when those mitral and tricuspid atrioventricular valves are shut, when they close, that's the lub sound, that first sound, okay? And they're closing, right? Right after you fill that, right? So it needs to be filled before that can happen. So the second they shut, you're starting systole. You're starting the ejection phase because you're going to squeeze all that out, right? You just ended diastole. They're already filled. You're shutting it off so that you can eject it now out of the semilunar valves, okay? So that second sound, dub, S2, is produced by turbulent blood flow through the semilunar valves, and those pulmonary and aortic valves are going to close once ventricles are done squeezing. That sound of them closing is that dub sound, okay, S2. All right, we'll do this in a lab. We'll have a few different places for you to listen around the heart. These are the 5 typical areas of auscultation: tricuspid, bicuspid, or mitral. Pulmonic has 2, a primary and a secondary, and then the aorta. We'll see all those in lab. Okay. All right. So again, systole, what is it? Ventricular contraction. The atria are already filled. They're ready to be, the blood is ready to be ejected to the rest of the body. So that is systole. Diastole is when they are filling, right? Ventricles are relaxed. They're not contracted because that would shoot the blood out. They're completely relaxed. Cardiac output is important. It's the amount of blood pumped by each ventricle in 1 minute. Okay, so it's how much, right, is going on. So that's actually a product, which is multiplication, of heart rate, which is contractions per minute, so beats per minute, right? So when you listen to your heart rate or count your heart rate with a watch or with your fingers, you're here, any pulse, right, is going to be your heart rate, multiplied by stroke volume, which is the volume of blood ejected from each ventricle. So you have to multiply those together to get your cardiac output. Okay. All right, the end systolic volume is the total volume of blood left in the ventricles at the end of systole. Remember, systole is ejection. And diastolic volume is the total volume of blood in the ventricles at the end of diastole, when the blood is filling. Okay, we'll do blood pressure in lab. So you'll have actual manual practice with this, and these concepts will set in a little bit better when it comes to that. But I really want to go over this chart. So how to measure blood pressure. Blood pressure is when the left ventricle ejects blood into that aorta through that aortic semilunar valve, right? And so aortic pressure is going to rise. The maximum arterial pressure following ejection is called systolic pressure. Okay, don't describe systole when you're describing systolic pressure. Systolic pressure is specifically maximum arterial pressure following ejection, not just systole, the actual pressure. All right. Minimal arterial pressure following ventricular relaxation is diastolic pressure. So heart at rest versus contracted. Okay. So you're trying to find, when you do a manual blood pressure, systolic pressure and then diastolic pressure. So you're trying to find the two pressures, heart after contracted, heart relaxed. Okay. What we do is we put this cuff on and make it really, really tight. That's typically not very comfortable, and it's uncomfortable for a reason. You are squeezing so hard that you kind of stop that blood flow from going to that region. When you're listening with the stethoscope after the cuff, you shouldn't hear anything because no blood can get down there, right? So you can't hear anything yet when the cuff is really tight. When it's high pressure, when the cuff is over here, when the cuff is so high pressure, it's above your heart pressure. If your heart pressure is higher than the pressure of the cuff, then by definition, it can go through the cuff, right? But if the cuff is higher, you're not going to hear anything, okay? You're not going to hear anything until suddenly blood starts to get through. When blood starts to get through the cuff, you hear these cord cough sounds. And cord cough sounds are the sound that is happening in the high pressure constricted vessel, right? It's pushing as much as it can, but only a little bit of blood is getting through, and so you start hearing these kind of clicking sounds almost, or whooshing sounds maybe, whooshing. To me is what they sound like, but everyone kind of describes them a little differently. You'll get practice in lab. Okay, so as the pressure in the cuff is decreasing, more and more blood is allowed to enter, which means those cord cough sounds are actually decreasing because it's easier for the blood to get through. And if it's easier for the blood to get through, you're not getting as much of that turbulent sound as in the beginning. Right? So when you start hearing there's weird sounds, that's your first number. When you stop hearing those weird sounds, that's your second number. Okay. If that didn't make any sense to you, that's perfectly fine. We'll do this again in lab. Okay. And this is just a combination of connected facts, right, from us learning here, here, and here about blood pressures mixed with when you should expect to hear those sounds. Okay, let's talk about hypertension and hypotension. So blood pressure is described, if it's normal, typically you have a systolic of less than 120 and then a diastolic of less than 80, right? If any of those numbers are greater, then you may be considered elevated. Or I'm sorry, if systolic is greater and diastolic, diastolic is not typically how I should put it this way. Diastolic is typically not how we diagnose this. Systolic is going to be your main one for figuring out if something's wrong. So I would always look at systolic first, unless diastolic is more than 10 off where it should be. So if you're, less than 80 for diastolic, that could mean that you're normal, right? Either one. Let's say you're 78. Could be. But, if your systolic is 130, right, then you do have hypertension, right? So I would look at systolic before looking at diastolic in that case. But these are your guidelines for that. Elevated stage 1 is going to be between 130 and 139. Elevated is between 120 and 129. Stage 2 is going to be over 140, and then a crisis is going to be higher than 180. So less than 120 is normal. Between 120 and 129 is elevated, but potentially not a cause for concern considering the context. Hypertension stage 1 is between 130 and 139. high blood pressure, hypertension stage 2, above 140, and then a crisis would be above 180. Right? You really don't start to see diastolic changing and increasing until we get to stage 2 and stage 3. I do want to mention hypotensions when it's too low. Very rarely, right, we see that as an issue, but that would be diagnosed hypotension below 90 and below 60. But you have to be below 90, below 60, not in the 90s, in the 60s. So make sure you understand what this is. Okay, let's go over the conduction system of the heart. I love the conduction system. We learned about the plumbing before, and what I mean by that is we learned about the physical structure. Now we're going to talk about the electricity of it all. Okay, so here, how does the heart know when to pump? Right? And they don't all pump at the same time, right? Or we would have systole and diastole at the same time, and that's impossible. So we know there has to be an order to the brain, and in this case, the heart itself pumping. So let's start here at the sinoatrial node. This is called the pacemaker of the heart because it controls when everything else is going to pump. You can follow the signal from the sinoatrial node. It's here located in that right atrium. It's also why I like starting in the right atrium when talking about plumbing, because it follows the conduction system quite well. Sinoatrial node is going to talk to this atrioventricular node that's kind of between the right atrium and right ventricle here. That's why it's called the AV node, atrioventricular node, right in between them. So SA talks to AV just to tell the signal to keep going. Okay, that's going to make those atria contract. Essentially, the contractions follow where the signal is going. So if the signal's in the atria will then contract. Then it'll go into this atrioventricular bundle. This is also commonly called the bundle of His, H-I-S, or atrioventricular bundle. Okay. Then down the interventricular septum, so between the ventricles, there's this septum separating them. It splits into a left and a right bundle branch. That makes sense because we were just at the atrioventricular bundle. Now we have these branches, left and a right branch. Those are each going to curve around the opposite sides of the heart, wrapping themselves around the ventricles. What do we think is contracting if they're wrapping around the ventricles? The ventricles are contracting. So those, once we get along the outskirts, we're going to call ththose Purkinje fibers. Okay, so we go from SA to AV, to the atrioventricular bundle or bundle of His, down that septum as left or right bundle branches, and then those curve into Purkinje fibers wrapping around the ventricles. Okay, that, believe it or not, is what gives us this electrocardiogram, right? So how do we read this? When we place nodes on the body, I'm just going to do a quick demonstration here. If you've ever had electrodes placed on your body, so the three really important ones that you need for this to work at all, one there, and then one down here on your leg, right? So one on either side, just left and right of the clavicle, or sorry, below the left and right clavicle is what I meant to say, and then one on the left leg. Well, why do we choose the left leg? Well, we need the current to be able to pass between all three of those axes, right? We'll look at these axes. We can check the atria, and we can check right down that interventricular septum, right? And that's the pathway for nodes. That's why we place those nodes where we are, because we're trying to get something that looks like this, trying to get the machine to read those electrical signals from one electrode to the other and tell us what exactly is happening. Okay. When we get this little bump here, that is referred to as the P wave. That's measuring the electrical impulse here. Okay, so in the atria. So it's measuring the impulse here. That is a depolarization. Okay, depolarization of the atria. So the atria are depolarizing at the P wave. It is absolutely integral, significant, important. Write it down, highlight it. You need to know what every part of this electrocardiogram tells us. Okay? P wave is a depolarization of the atria. What does it mean to depolarize? It means that that signal has traveled and told the atria to contract. So if you're depolarized, you have contracted those atria. Okay, then we get this QRS, huge leap, huge spike. Okay, well, if this was depolarization of the atria, what do we think this big spike is? Well, the ventricles are a lot larger than the atria, aren't they? So we should see a bigger spike in that electricity. How much electricity is being picked up there when the ventricles contract. So QRS is ventricular depolarization. Okay, depolarization. It means the ventricles have contracted. So now we've seen where the atria have contracted and the ventricles have contracted. But here's the thing, if we start the cycle over, we can't depolarize the atria again because they're already depolarized. You have to repolarize the atria, meaning we have to relax the atria. If the atria are contracted and they stay contracted, you can't contract them again. They have to relax, just like a muscle. That's what the heart is. It's a muscle. So we know that they've contracted here, and we know that the ventricles have contracted here. So atria contracted, ventricles contracted. When on this do the atria get to contract? To relax, I mean. The atria relax actually during ventricular contraction. And ventricular contraction spikes so high that you don't see any electrical impulse of the atria repolarizing because the ventricle depolarization completely covers it up on the graph. This is time along the bottom. So the atria depolarize, they contract. When they relax, it's the same time that that signal has now traveled down. It's traveled to the ventricles and they're now contracting. So it's the same time that those are contracting. Right? So it happens at the same time. We don't see any extra blip. It disappeared. Doesn't mean it doesn't happen. It just means that on this graph we can't see it because it's overshadowed by ventricular depolarization, ventricular contraction. What we can see is ventricular repolarization. So when the action potential goes back, right, we get a repolarization after the action potential, I mean. It goes the opposite way. We get this T wave. That is ventricular repolarization. So on an electrocardiogram, we can see atrial depolarization, contraction, ventricular depolarization, contraction, and ventricular repolarization. We can see 3 out of 4. We can't see when the atria relax, repolarization. Okay. All right, so just to go over what each one of these, why each one of these is important. P wave tells you that the atria are contracting. QRS complex tells you that the ventricles are contracting. Another way we know it's contracting, depolarization. So these are both representative of depolarization of the atria and the ventricles respectively. T wave, repolarization, relaxation, relax, repolarize, okay? So those words go together. That's for the ventricle. And remember, we can't see when the atria repolarize, when the atria relax, but it happens during QRS. Okay. Then we get into some of these segments here. So the PR segment or interval here is essentially everything that's happening above the ventricles. Okay, which means it's focused on what's happening in the atria. If we just look at the segment here, that's important because it's the time between the atria contracting and the ventricles contracting, which means if there's a blockage in this conduction pathway, if the signal gets stopped between, we'll see that here in that PR segment. So that will tell you if there's what we call a heart block, which is a conduction problem. There's a signal not getting through to the ventricles because that PR segment's going to be elongated. QT is essentially the entire time for the inferior valves. I mean that in the anatomical sense. So it's below, right? So the ventricles is happening between Q and T. Okay, everything having to do with the ventricles. The ventricle contracting and relaxing happens between Q and T. R to R is a complete cycle, right? So going from one R peak to the next R peak, R to R, that's one heartbeat, one complete heart cycle. So that can tell you how fast the heart's beating. If they're close together, the heart's beating very quickly. If they're far apart, heart's beating slowly. The ST segment is fascinating and is clinically relevant because it will tell you if there's any disruption of the electrical impulses between ventricular contraction and relaxation, which will actually tell you if there's an infarction, right? So if there's dead tissue in the area, if blood's not getting where it needs to, if there's a lack of oxygen in those tissues. And so that can be one of your first signs of myocardial infarction. Okay, so let's look at some EKGs for examples. Bradycardia, brady Latin meaning slow. So if the R to R peaks are far apart, you have a slow heartbeat. If the R to R peaks are close together, they're very fast. Now, these are only pathological. This is very important. Pathological means there's something wrong, right, clinically. These are only pathological in the correct context, okay? So if you're sleeping and your sinus rhythm is less than 60 beats per minute, that's not pathological, unless it's like really, 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 really low, right? Probably okay. If you're in the 50s while sleeping, sure. If you're in the 50s, I don't know, while exercising, and you're not an Olympic athlete, that might be a problem, right? So it just depends on context. These aren't absolutes. These are context dependent. Sinus tachycardia, same thing. So this is just your heart rate's higher than 100 beats per minute, right? If you're exercising, that's not a problem. We expect that. Sinus just means the plumbing is working fine. The heart is beating as normal, it's just fast or slow. So sinus tachycardia means the heart is fine, it's just beating fast. If you're sleeping and have sinus tachycardia, that's pathological. You don't want that, right? That means something's likely wrong. But if you're exercising and have sinus tachycardia, that's okay. Okay. Something I have, actually, is supraventricular tachycardia. I have I think I have an image of it here. All the way back, my apologies, right here. A fossa ovalis means like an imprint, like a little thumb imprint here. Adults have a fossa ovalis. Fetuses inside a mother, or inside the womb, are a foramen ovalis. It goes all the way through because they're breathing through the mother and the placenta, so they don't need their lungs to expand at all. So they just totally go through that. They don't need to go to the lungs. They bypass it through the foramen ovalis. Mine is open, which is very common actually. And I also have a left atrium that's prolapsed, as well as a prolapsed mitral valve. So I have a lot of inefficiencies happening with my heart, and so if I exercise, which I do to stay healthy, I will have supraventricular tachycardia without my medication. Without medication, I can hit 260 beats per minute. It would be impressive if it wasn't pathological. Resting without medication, I'm at 125. beats per minute. So whenever the heart rate is above 200, you typically hit supraventricular tachycardia, sometimes over 150 even. And that essentially means we have QRST, but P's missing because P's happening at the same time that T's happening, so it gets overshadowed again. So you have a missing P wave because of that. Let's go through some more abnormalities or pathologies on an EKG. Atrial flutter means that the atria are contracting consistently, but multiple times before the ventricles contract. So you see a consistent 1, 2 ventricles, 1, 2 ventricle contracts, 1, 2 ventricle contract. You get these sawtooth kind of slanted triangles for atrial flutter. Okay, and they always kind of go together. So you can have 2 before the ventricles contract, 3 before the ventricles contract, 4 before the ventricles contract, but either way, it's always consistent. You either have 2, 3, or 4. Every single time, it's always the same. That's flutter, atrial flutter. When it's a mess, that's the best way I can put it, that's atrial fibrillation or AFib. Okay? The ventricles, look at them, beautiful. QRS, complex, beautiful. Now not consistent whatsoever. They're a completely different distance apart from each other, right? Is the heart beating fast or slow? I can't tell. It depends on the millisecond, right? The atria don't have these beautiful, consistent saw-like patterns. They are just chaos, fibrillation, okay? The signal is bouncing just chaotically from SA to AV. It's bouncing all along the chamber until it finally hits AV, and then it triggers the ventricles to eventually contract, right? So this is the signal trying to find the ventricles, There's a disruption there. Okay. For the ventricles, they have their own versions of these that are completely independent. Okay, so ventricular tachycardia, you get these very wide QRS complex, not these nice spikes. See how beautiful these QRS are? Even though there's an issue with the atria, ventricles are acting fine. Okay, here, not so much. Ventricles not acting fine. These are both medical emergencies. Differ in severity, both medical emergencies. Okay. The P wave's going to blend with that QRS complex. It's all going to be in there together. Okay, but you still get a contraction of the ventricles. It's just not standard. Here, ventricular fibrillation is actually cardiac arrest. So in ventricular tachycardia, the heart's beating so fast, but it's still beating. You have a pulse. You could feel a pulse on an individual. They need to be shocked back to a normal rhythm, but they have a pulse. Okay? Ventricular fibrillation, you would not feel a pulse. You would be able to see on an EKG the signal, but would not feel a pulse. It is cardiac arrest. The heart is not beating. The ventricles to create these are pulsing like this, but not fully contracting. Okay? So you don't have circulation, right? That is cardiac arrest. That would require immediate CPR and defibrillation, right? This would also cause at least defibrillation, try and shock it, but the person could be awake, could be talking to you, has a pulse, right? The individual would not be. Okay, something that you need to know, if there is no pulse, if this is a flat line, there are no electrical impulses. You cannot shock that. You cannot defibrillate something that's not there. Defibrillate means you're undoing the fibrillation. If there's no fibrillation, you can't undo it. Okay? There's nothing to fix if there's nothing there, unfortunately. Right? So that's why you would do CPR, attempt to get some sort of electrical impulse back. When you have an electrical impulse, then you can shock it, then you can defibrillate. Okay, AV blocks. That's that PR segment we talked about, right? Is the time it takes to depolarize that atria, to contract that atria, for that signal to then get to the ventricle. Get to the ventricle, okay? This section, PR, okay? That section right there. If that segment's really long, you know that the signal is taking a longer time than usual than get to the ventricles, and you know that there's a block. These degrees are just how bad that block is, right? So first degree is anything greater than 0.2 seconds. Okay, just a little bit of a delay. Second degree, worse than that. Third degree, no talk between them whatsoever. Okay, so the ventricles are going to be waiting for the signal. They're not going to get it, and they're going to get nervous, and they're going to go by themselves. Okay, you don't want that. But the ventricles do have a fallback system, and they will contract if they don't get a signal for a very long time. Okay, but that is no talking between the atria and the ventricles. Completely random ventricular contraction. Okay, so slight delay is first degree, long delay is second degree, but they're still talking to each other. Third degree, no communication, ventricles contract independently. And that is it for cardio.